Good afternoon, everybody. Thank you very much for coming to today's Controversies in Cardiology. We're privileged to really have a very august panel on a really hot topic. Just to let you know, in the next couple of months, we have some very exciting programs. In March, we have Dr. Robert Califf, formerly of Duke, formerly of the FDA, currently sort of Chief Medical Officer at Alphabet, which is the parent company of Google. And the topic is going to be artificial intelligence in cardiology. Dr. Nishimura will be coming in April. We're privileged to have Eugene Braunwald in May, and he'll do a one-on-one sort of fireside chat with Dr. Fuster. And last but certainly not least, in June, Dr. Marty Leon from Columbia. Today's topic, like I said, we're privileged to have on our panel leaders in the field, both from an electrophysiological point of view. Mark, people are usually sitting up front. Can you mind coming up front? Thanks, Mark. Thanks, Mark. So we're really privileged to have a very august panel that Dr. Reddy will introduce in a few minutes. First, I want to introduce Chris Pummel, who's the cardiology fellow, who put together a very interesting monograph, which is available right outside. And the topic is atrial fibrillation, where to after Cabana. Chris?
Hey, everybody. So atrial fibrillation is the most common arrhythmia in clinical practice, responsible for 1/3 of all arrhythmia-related hospitalizations. In the last 10 years, the number of AF-related hospitalizations has nearly tripled and is predicted to affect up to 16 million people by the year 2050. Pathophysiology of Afib is believed to be caused by aberrant left atrial foci. Paroxysmal Afib is believed to be due to rapid discharges from the pulmonary veins, while persistent Afib is thought to be due to adverse remodeling from chronic cardiac pathology. While this can develop in a structurally normal heart, it is much more likely to develop in those with other cardiac comorbidities. The initial decision in the management of Afib includes controlling ventricular rate and anticoagulation, while subsequent decision includes conversion back to sinus rhythm. This decision is highly individualized, taking many factors into account, including symptom frequency, severity, presence of other comorbidities, and adverse effects of antiarrhythmic drugs. Antiarrhythmic drug therapy is one available approach to maintain sinus rhythm and is estimated to reduce the one-year recurrence rate of Afib by approximately 50%. These drugs are not without adverse effects, as many are pro-arrhythmogenic, and discontinuation rates are nearly 40%. Alternatively, catheter ablation is another approach for rhythm control, and in the hands of experienced operators, one-year freedom from Afib is generally about 75% for paroxysmal and 60% for persistent atrial fibrillation. Repeat ablation can also be performed in the setting of recurrence. In the late 1990s, there were many reports of decreased mortality in patients undergoing catheter ablation when compared with drug therapy, and the recently published Cabana trial was developed to answer this question. The initial endpoint was all-cause mortality, but due to slow enrollment, a modified design adjusted the primary endpoint to a composite of all-cause mortality, disabling stroke, serious bleeding, and cardiac arrest. In the initial analysis, there was no significant difference in the primary endpoint, but the secondary endpoint of all-cause mortality and cardiovascular hospitalization was significantly reduced in the catheter ablation group. This is mainly driven by reduction in hospitalizations. That being said, about 25% of participants in the medical therapy group did cross over, which led to a significant decrease in the primary endpoint using a per-protocol analysis. While controversial, Cabana was reported as a negative study. Thus, in light of these findings, this paper attempts to examine if mortality should be the principal endpoint in atrial fibrillation trials. While there's clearly an important investigational endpoint, one can argue that there are many other endpoints as important as mortality. Patients with Afib have similar quality of life scores to those with recent myocardial infarctions and congestive heart failure. Antiarrhythmic drugs, pulmonary vein isolation, and AV nodal ablations have all demonstrated improvement in the quality of life of these patients. Neurologic outcomes, including dementia, have also become increasingly associated with Afib, as this presence is associated with a 36% increased risk of dementia over a 5-year period, and this is after adjustment for other comorbidities like ischemic stroke. A large retrospective trial recently demonstrated the rate of dementia in those undergoing ablation is no different than patients without a history of Afib. Additionally, Afib is associated with a 3-fold increase in the risk of incident heart failure, while up to 50% of patients with heart failure will develop Afib at some point in time. Nonetheless, the presence of both Afib and CHF was associated with a significantly worse outcome. There are multiple randomized studies that have demonstrated improvement in outcomes commonly used in most heart failure trials. Not only is there improvement in subjective endpoints like quality of life and NYHA class with catheter ablation, but also many objective outcomes, including ejection fraction, CPET scoring, number of hospitalizations, and LV dimensions are all also improved. Lastly, due to the high hospitalization rate, coupled with costly complications such as stroke and heart failure, Afib is a significant healthcare burden, with the total annual cost estimating nearly $7 billion. Recent data concluded that catheter ablation was associated with a significant reduction in both hospital stays and total cost. In conclusion, Afib is a comorbid disease, highly associated with heart failure, increased risk of death, and other cardiovascular and thromboembolic complications. The above-mentioned data demonstrating improvement in both subjective and objective measures, along with the reduction in healthcare expenditure, warrants the consideration to include these additional endpoints in upcoming Afib trials. Thank you.
Thank you very much, Chris. So we're going to get started in just a few minutes. First, I want to introduce our guest today, Dr. Marcinski, and hopefully many of you were at his noon talk. It's common, especially in meetings like this, to talk about and wax poetic about and ecstatic about how great our next speaker is and how much he's done for our field. Well, in a land of giants, Dr. Marcinski stands a little bit above most. He's had an incredible impact on our field in electrophysiology. He's been practicing for many years. And he's basically touched every aspect of electrophysiology: device therapy, catheter ablation, whether it's SVT, VT, most recently atrial fibrillation. He is the Richard T. and Angela Clark President Distinguished Professor of Medicine at the Perelman School of Medicine at the University of Pennsylvania. He's been the Director of Electrophysiology at the Penn Labs for many years. After graduating from the University of Pennsylvania Medical School, he did his postdoctoral internal medicine residency and cardiology and electrophysiology fellowships, again at the University of Pennsylvania. And he has certainly remained at the cutting edge of cardiac rhythm management. If you want to know what's going on in electrophysiology, just read his papers. He has about 500 plus papers. And it sort of gives you an idea of what's been happening in our field for all these years. He serves on multiple guideline committees and has been involved in the guidelines for both atrial fibrillation and ventricular tachycardia management. He's received a number of awards, including the Luigi Mastriani Clinical Innovator Award, the Venice Arrhythmia Distinguished Scientist Award, and the ACTS Distinguished Investigator Award. He's on the editorial board of multiple publications, and probably, maybe perhaps the biggest impact he's going to have is he's trained a number of fellows. The University of Pennsylvania has one of the largest fellowship cohorts. In fact, Dr. Langen here graduated from the University of Pennsylvania. And beyond his own personal training, he directs a number of regional and international courses, including, and I'm lucky to co-direct the VT Symposium, which is now, I think, on its 15th year, right? We're getting up there. And of course, he's received numerous teaching awards at the University of Pennsylvania. So with that introduction, I'd like to invite Dr. Marcinski to come up and receive the award. So please, Frank. So I'll just read this to you. This says, the faculty and fellows of the Zena and Michael Wiener Cardiovascular Institute and Marie Jose and Henry Kravis Center for Cardiovascular Health express appreciation to Francis Marcinski for outstanding teaching, wisdom, and expertise as the Anandi Sharma Visiting Professor in the Simon Dack Memorial Lecture on February the 24th, 2020. And I can also invite Chris to come up, and we have to memorialize this with a picture. Fantastic. Oh, importantly, the check. So actually, Frank, please come on up here. I'm going to invite the rest of our panel. It'll be Srinivas Dukapati, Jonathan Halprin, Noah Langen, Noah Moss, Sean Pinney, and of course, Chris Pumo. And let me give you, we're going to have a few slides. You guys can't turn around. Don't worry, you don't have to.
First of all, Vivek, I do want to say I'm honored very much by this award, very much by the invitation to be here. I have so many friends in the audience. I appreciate this opportunity to you, Dr. Fuster, the whole team. Everybody's been very generous with their time and their interest. I love to talk, so thank you for giving me that opportunity, especially to talk about electrophysiology. So thank you again. It's a real honor.
So with that, let's get right into it. So as Chris laid out in, as Chris laid out in his introduction, Cabana has had certainly a big impact on our field, I would say. It certainly impacted what we talk about. And the question is, what is the impact actually? So I want to start off with this slide. So this first slide shows some of the outcomes from Cabana. We'll get into the details of Cabana, but if we think about AFib recurrence, what you see in the left graph is catheter ablation versus drug therapy. And these are patients followed out for almost 5 years, and you see a significant improvement. The hazard ratio is 50%, is 0.52, so about a 50% decrease in AF recurrence. And on the right is one of the 2 quality of life measures that was used. Now, I don't expect this to be a particularly controversial slide, but just to get things started, Frank, I'm just wondering, when you look at this slide, it doesn't look that dissimilar from many other trials that we've conducted. In fact, they all look relatively similar. What, if anything, would you say is different about Cabana and how we think about the results of Cabana, and just in terms of AFib recurrence and quality of life, if anything?
Yeah, I think that we've got more conviction with a large number of patients that have been randomized that ablation works to prevent recurrent atrial fib when compared to drug therapy. So that's unequivocal, and it improves, as a result, the quality of life. So this is a large prospective randomized study, multiple centers involved, and you can walk away saying, without a doubt, that we've got a therapy that works.
Okay, I think that's fair. Now, let's go to this slide. These are the 2016 ESC guidelines, and they're not dissimilar from some of the other guidelines, so I'll just use this one because it fits on one slide and is easy to read. So, at least at the time, basically the guidelines were that regardless of underlying substrate, whether on the left, no structural heart disease, in the middle, coronary disease or other ventricular hypertrophy, et cetera, or on the right, heart failure, the idea was, okay, it should be patient choice as to whether or not you receive an antiarrhythmic agent, a membrane-active agent, that is, you see in the blue squares, or catheter ablation. And my question is, how do you agree with this? How often do you consider catheter ablation in your practice? And because this is basically saying it's first-line therapy. So maybe, Srini, let me go to you first. What do you think about this?
Yeah, I think I agree with this.
Oh, please speak into the mic, everyone.
Yeah, I think I would agree with this. I think the days of marinating people in antiarrhythmic drugs that just don't work are past. And with the current state of AFib ablation, there's no doubt that I think I'd put it ahead of antiarrhythmic drugs at this point in select patients and not even be a choice.
So what do you think about that, Frank? How often do you consider, if a patient comes to you, and let's say they've just been on a beta blocker, paroxysmal AFib, and let's just start with the no substrate, no structural heart disease. What is your discussion with them in terms of whether you consider ablation or let's try an antiarrhythmic first?
No, I always give them the option. And I tell the story, I take care of 10 of my colleagues that have graduated from medical school with me and have developed their atrial fib, so I always tell them that. And I think that, I said, they're all physicians, so this gives you some idea about how physicians are approaching this. And I say some physicians walk in and they clearly want to have this eliminated. They don't want to be a patient, especially since I've been doing this for a while, taking care of them, especially at a young age. They didn't want to be a patient. And they said, I want to undergo an ablation procedure and I heard you do it reasonably well. So how do we get it on your schedule? So there's a lot of interaction with the patient. That type of patient, we encourage the option of ablative therapy early in their clinical course. For most patients, I sit with them and say, look, it's not unreasonable to try an antiarrhythmic drug. The option of ablation is reasonable, but we can't wave a wand. We have to do a procedure. Procedure carries a low but definite risk. So if you're risk averse, you might want to try an antiarrhythmic drug. And if you have any side effects from the antiarrhythmic drug, you don't like taking it every day, you have the option of ablation. So I don't necessarily channel them to ablation therapy, but I tell them it's not unreasonable to consider it as a first-line treatment. And I tell them my medical school colleagues were proof of that they jumped at the opportunity, several of them, to get the procedure done after thinking about the options. And I think it's good to, listen, I always say to the patients, if you happen to be lucky and respond to beta blockers and you're not having recurrences and you're tolerating the medication, we don't get dumber, techniques don't get worse, technology doesn't get worse. So you'll have the opportunity for a better procedure because it probably won't last forever. And you'll probably have more and more recurrences over time. You can undergo the procedure then. Same thing with an antiarrhythmic drug. But if you fail one antiarrhythmic drug, not beta blockers, but the chances of the next one working, we know from a clinical experience, it's 20% or less. So when you tell most patients that, they go 20%, I said, yeah, it may even be closer to 10% the reality. And they'll say, well, listen, I'll try one drug, and if it fails, I'll move forward to ablative therapy. The good news is we've got pretty convincing data that ablative therapy has gotten less risky and more effective, and it's not unreasonable to consider it as a first-line option. It doesn't mean it's the preferred choice, but in selected patients, it is the preferred choice.
John, let me ask you, from your perspective as someone who occasionally sends us some patients, how do you decide on this issue of first-line therapy versus not first-line therapy?
I agree with Dr. Martlinski. I think it's something you discuss with the patient. I always offer the patient an antiarrhythmic drug first and indicate to them that they don't have to take that pathway. They can certainly go in the direction of an ablation procedure first. And typically patients who have, for example, a family history of atrial fibrillation and a parent or a sibling who had lots of difficulties with antiarrhythmic drugs over a long period of time will say, I want to skip that and go right to an ablation. I think that's perfectly reasonable. Since we have fairly innocuous drugs like dronedarone, they're not all that effective, but at least they don't cause much trouble. It's easy enough to offer a first stab at that. And then when it fails, say, okay, now, and as it often does, then to say, look, you will find ultimately that an ablation is going to be much more effective at relieving these symptoms. And so we can go down a path of additional medications, but you should start to think about the procedural approach.
Noel, let me ask you, we're going to spend most of the time talking about AFib, but just for a minute about atrial flutter. So when a patient presents with typical atrial flutter, well, you assume it's typical, no history of structural heart disease, let's say. How do you treat that patient differently, if at all? No, I'm going to go to Noel.
So for the atrial flutters, I will almost always give them one cardioversion, and then I will 99% go the ablation if they recur. But rarely I will do the very first flutter ablation, except heart failure associated.
So flutter in the setting of heart failure.
Right, very, very
Yeah.
symptomatic. Traveling people. I mean, there's occasions where obviously you don't want to have to deal with a second. But so I would say 90% will get a cardioversion as number one, and then definitely ablation the second time.
Okay, let's move on to Cabana, the big C. So you already heard from Chris in terms of what Cabana was, and there are three aspects that I just want to point out that were different about how Cabana ended up compared to how Cabana was intended. The first was that there was slow enrollment, and this resulted in an expected sample size re-estimation from 3,000 patients down to 2,200 patients. That also was a change in the endpoint from mortality to a composite of mortality, cardiac arrest, and major bleeding, and stroke, disabling stroke. The second was, as pointed out, there were patients in the ablation arm that did not undergo ablation. And it turned out the main reason for this was actually economic. So patients were randomized to ablation, and then this was outside the United States, and then the patients had to pay for the procedure, and apparently that hadn't been discussed, or maybe they changed their mind, or whatever. And the third point was that there were patients that crossed over from the drug therapy to ablation. And again, in some sense, this is not a terrible surprise. You do expect that in an ablation trial. In fact, the investigators did expect this. The problem was they didn't expect the confluence of all three of these events. So you ended up with a study that was, I think, most people would agree that this was an underpowered study. So the primary endpoint of death, disabling stroke, bleeding, cardiac arrest, there was no difference in between groups. If you look at all-cause mortality, again, hazard ratio of 0.85, but wide confidence intervals, no difference between groups. The other point, as Chris pointed out, if you then do the secondary analyses, the per protocol analysis and the treatment received analysis, what you find is that there was actually statistically significant differences. There was an about 30% decrease in mortality if you look in the per protocol, and similar in the as treated or the treatment received using several different statistical methodologies. So the question, I guess, is, there's a few other pieces of information. I'm only going to show this propensity match analysis, though there have been a number of these that have been published over the years. This was published along the same time that Cabana was published, and this was looking at the Optum Labs administrative database of 183 patients with atrial fibrillation who were either treated with ablation or meds. So these are patients undergoing ablation or receiving meds in clinical practice. And these investigators did a propensity score weighting with multiple factors, 90 different factors that they weighted, that they matched for. And they were able to, again, because of the number of patients. And ultimately, they looked at 12,000 patients who underwent ablation and matched those to 171,000 patients who are receiving antiarrhythmic drugs. And they looked at the same primary endpoint as Cabana, and they did see similar hazard ratio, but because of the numbers, a highly statistically significant result. If you look at mortality alone, again, they saw about a 30% reduction in mortality with tight confidence intervals. That's the second piece of information. And the final, and you can take this for what it's worth, this is a little bit, I'm sorry, let me stop there. This is one last piece of information. There was a surgical randomized trial. I'm going to show this for just the sake of completeness and because it was published relatively recently, where these are patients who underwent surgical AF ablation or not, in patients undergoing surgery for something else and also had AFib. And what they saw was with this composite endpoint, again, a significant improvement in the ablation patients versus control. So let's take a look at these three pieces of data. So, I think that most of us would agree that the patients who have symptomatic AFib, you treat them with something. You treat them with medications. If that fails, maybe ablation, et cetera. The question is there a mortality benefit from AF ablation? Obviously, we know the top-line results of the various studies. We know the propensity match studies. So what do you do with this information? Is it interesting information that you ignore? And I guess to properly frame this question, let me put it in the context of, let's say you have a 55-year-old person, a 55-year-old man who has maybe some hypertension, not much else, and has atrial fibrillation that was detected recently on routine EKG. Patient doesn't know, they didn't know that they were in atrial fibrillation. So how do you approach this patient? Frank?
Yeah, well, I do want to say that a couple of things about the Cabana trial, because I think it's important to know. One, that the requirement for entry was that they had some symptoms. So this is a symptomatic AFib, though people obviously had AFib without symptoms mixed in with their symptoms. So one. Two, when Cabana, the idea for a Cabana trial started, and I got to be involved with it, which went down to the NIH.
Wait, I'm sorry, I have to interrupt you. I just want to ask you something about your first comment.
Go ahead.
Do you think symptomatology matters in the sense of hard endpoints like mortality? Is there a biological reason why?
I just want to necessarily, the answer is that it turns out that people who are asymptomatic tend to have a worse outcome frequently because they're not getting anticoagulated.
Okay,
so
fine. Okay.
It's not necessarily linked, and maybe go in the opposite direction because you ignore the occurrence of the AFib and there's strokes. But I just wanted to point out that that was the requirement for Cabana. The second thing is when you think about when Cabana started, as I said, I got to go down with the NIH with Doug when we were talking about it, and then I disappeared. He carried on, and so God bless him. It was an incredible study. But at that time, it was about 2005. It was pre-NOAC era. And so you can imagine when even this was reviewed initially in the pre-NOAC era, when you had warfarin, and you had issue with variability in anticoagulation, it was dramatic. You had more noncompliance. You had, not that you don't have it with NOACs, but you had more. And there was really a thought that this was going to be a big potential stroke and mortality benefit from being aggressive. So that's how it started. And then it was assumed that we may have the same thing related to the NOACs. And it's good that NOACs are a little bit easier to take and patients are more compliant. And it probably has a benefit in terms of mortality and stroke that we didn't, recognize. And so that maybe it's harder to show, and we're underpowered with Cabana, because when you show these propensity matched patients, it's pretty impressive to say that there probably is a benefit. When you look at the on-treatment analysis, it was pretty convincing that there was a benefit. But it just points out, we thought there was going to be a lot more, and maybe the study was underpowered as a per protocol, analysis. So that's one thing. The second thing is your question for that patient. I think
Yeah,
is
my
really important.
55-year-old's waiting.
I looked at this not too long ago. Somebody said, how often do you see asymptomatic patients? It turns out 1/4 of the patients I see come in and have asymptomatic Afib. So it's a big deal. And somebody said to me, well, what do you do when they come in? And I said, well, first of all, I reassure them, because I think it's always good to be a caregiver and sort of reassure that you got Afib, but you're not having symptoms. And then I go through what I call the low-hanging fruit. Okay, and that is, I want to know whether they have decreased function. Because if they have decreased function, I'm changing the way I'm approaching them. I want to know if they've had progressive mitral regurgitation. And that if they have a series of echoes that now show more and more dilatation of the left atrium and more mitral regurgitation, I'm changing the way I'm approaching this asymptomatic patient.
Yeah, I'm sorry to interrupt you, but I forgot to put that in here. Frank, your group has published a paper on the fact that mitral regurgitation actually decreases in certain patients who have dilated left atria related to Afib. And you get rid of the Afib, the atria cuts a little bit small, the MR reduces.
And that's why now we sort of look at it and say, do they have decreased function? Is there an MR that developed temporally related to the onset of the Afib? And do you have any clue that that may have been the case? And did it progress? Because if they did, I have a different approach to those patients. I'm basically going, that Afib is bad. I want to try to get rid of it. You can talk about whether it's pharmacology or ablative therapy is just more convincing that the ablative therapy is going to work. So if they've got things going on, I lean in that direction. And then I sit down with them and I say, and sometimes I like to have the family member, wife or husband, and say, has there been a change in function? Has there been more dramatic weight gain and less activity, sexual dysfunction, other things that may be a marker that they have symptoms, and what's their exercise tolerance? Then I'll usually say, let me either get a monitor and tell you go crazy, push yourself, or I'll do a formal exercise test and see if their heart rate gets above 120 with the first 3 minutes of exercise. If they do, I said, they're going to get into trouble. And if their average heart rate at rest is above 90, I at least got to slow them down. And I'm leaning more towards, these are patients that are going to get into trouble. So I look for reasons why I want to be more aggressive. Now, if you're telling me a patient's totally asymptomatic, no MR, no EF lower, heart rate's 70 at rest, might be on a little beta blocker, and they're absolutely fine, I'm also telling them we don't know the answer to this. And I'm not convinced by the Cabana trial that I'm going to, just make a decision to intervene if they've been doing reasonably well and they're truly asymptomatic. So I think that's
Okay,
that's where I am.
so Srini, what do you do? Let's go through all of the things that Frank discussed, and let's assume that they're all negative, meaning the patient doesn't seem to exhibit these. How do you approach the patient differently, if at all, or the same? Or
sometimes give a trial cardioversion in these patients.
Yes, I did mention that, but I think that's important, especially if they're locked in it. If you're in and out of it, obviously not, but
absolutely. And so I think that's what.
So you do your trial, you cardiovert the patient, maybe you put him on a drug. It's 3 weeks later or 4 weeks later, the patient comes back to you and says, I didn't really feel that different.
Yeah. And then you have the discussion again, obviously, that, you didn't feel any better in sinus rhythm, you're truly asymptomatic. As far as we're concerned, all this workup has shown that you really have no symptoms, and really, I'm not sure, and the mixed data about whether putting you in a normal rhythm with an ablation.
So when you have the,
2B indication, right?
what's that?
It is a 2B indication.
It's a 2B indication.
To go and say, listen, you got AFib now for the rest of your life, anticoagulation for the rest of your life. So let's say it's a patient that's asymptomatic, he's got ulcerative colitis. I don't want him out of AFib. Okay, I don't want to anticoagulate him if I
Watchman.
really have to, right?
Yeah.
Watchman.
Or,
Wait.
I can talk about
No.
doing other stuff, but I
Yeah,
mean, I'd want him out of AFib if I could. I mean, and I'd want to be more definitive. If you take a 40-year-old patient that's in AFib and you got anticoagulation for the rest of their life, I would say, listen, do you really want to be in AFib for the rest?
So let me ask you, Frank, of this population, just guessing, what % of them do you think, in your practice, with your discussion, go on to ablation versus go on to stay as they are?
Biased, right? Because they're already sent to me.
Yeah, they're already sent to you, which is,
Somebody's already
right.
discussed this. They
Right.
said I do the ablation procedure. So it's a little bit of a bias. But there are people that come in and will have that discussion. We'll don't have to be balanced about it, but just say, do you really want to do this for the rest of your life? And I said, it's fine. But that's
Okay,
what
so
you're
it sounds
committing
like some of your patients go to ablation then.
Absolutely.
Okay, Srini? Noel? Oh, go ahead.
A little careful to separate paroxysmal from persistent, because we're mixing them up. And I have to say personally, because
So if they're paroxysmal, you're more likely to,
I'm very concerned about not getting somebody out of AFib if they're young
and paroxysmal?
and
Or persistent?
newly persistent.
And newly persistent. So if they're paroxysmal, you'll tend to follow them then?
Then I will tend to follow them also because things are changing, as we all know. But that, I feel a little more comfortable. But if you're 45 or 50 and you now become persistent, I think very hard about that because I feel like I'm condemning them to a fate that I cannot reverse. I hate
Okay.
making a decision that I can't reverse. I feel
Okay,
like that's
so,
what I'm doing.
so John, what do you think about this condemnation to a fate that we can't
So, first of all,
reverse?
I think I'm always very careful not to tell people about things they have to do for the rest of their life, because how the heck do I know it's going to be up in 5 years? You're going to have some oral therapy that obliterates the
I
left
say wave a
atrial
wand. If you
appendage.
want to
Yeah.
hang around for like wave a
Yeah,
wand.
yeah, that's it.
you may
So
do it.
I don't know, what to do about that. I do think that it is reasonable in young, otherwise healthy people to make reasonable efforts to maintain sinus rhythm. I think that, committing them for a long time to what will ultimately be a permanent AF situation, it'd be nice to avoid that. I also believe that even in an asymptomatic patient, we all practice what I call the dementia approach to atrial fibrillation. Everyone deserves one dementia workup, and most people deserve one crack at sinus rhythm. So I think those are all basic tenets that we tend to follow, not very evidence-based. I must say, I think when we talk about trying to demonstrate the long-term benefit in terms of hard outcomes, we have a pretty good randomized trial that's strongly, convincingly negative, and we shouldn't lose sight of that in Cabana.
But underpowered, wouldn't you agree?
Underpowered, I
Okay.
agree, but we certainly, it's, at least at that level, tells you that the number of patients needed to treat to demonstrate a hard endpoint advantage, not quality of life, but mortality or the other things that were incorporated in the expanded endpoint, you're going to take a lot of patients to demonstrate an advantage. Okay?
That is a good question. I don't actually know the answer to that. No, but if you look at
It's hard it's hard to calculate NNT when you have no difference in treatments.
No, but that's true. But if you believe the on-treatment and per protocol analyses, and there are reasons to believe that.
We should go to a per protocol analysis makes sense as a sensitivity analysis when there is in fact a difference in the intention to treat, and you want to be sure to kind of validate it. Then it makes sense to look at a per protocol on treatment analysis. When in a negative trial, all you're doing is converting a randomized study into an open label study. You're ignoring all the time that they did spend on the initial therapy because you're dumping them into the final endpoint. There's a lot of problems with doing that, and I certainly wouldn't use it as a justification. Sorry.
Okay, let's go to this one. I mean, I guess the counter argument to that is, I think you're absolutely right. In the context of the trial, there's no doubt that that's how you have to interpret it. But in the context of clinical practice, I mean, we practiced before Cabana was published, right? Did Cabana push, yeah, that's a good question. Did Cabana push you in any direction? Did it push you toward thinking it's more likely to have a mortality benefit, or did it push you toward thinking it's less likely to have a mortality benefit? Sean, I was going to wait for the heart failure questions, but I need to.
Now, Cabana proved, if you accept it, it proved my bias, which is that there's never been any data to show that AFib ablation improved mortality. And so it was reserved for patients who were symptomatic. There are only two reasons to do anything in medicine. The first is to improve symptoms, the other is to improve survival. And so for patients who have refractory symptoms, who are refractory in spite of either rhythm control or rate control, then it's reasonable to do AFib ablation. But the real kicker is whether or not you can prove there's mortality benefit. And based upon Cabana, you cannot. We'll talk about the heart failure subgroup.
No,
next,
separate.
but
We'll talk about heart
separately.
failure separately.
But no, it did not persuade me
No,
differently.
that's not, I guess that's not my question.
after
Did it
Cabana.
push you more toward there is a mortality benefit, or did it push you more toward it isn't, or you're where you always were?
My feeling was that there was not a mortality benefit associated with AFib ablation, and for all comers, and that was confirmed by Cabana. So it didn't change me one way or the other.
Didn't change. Noah, how about you?
No, I don't think it pushed me one way or another in terms of that specific question.
That's interesting. I got to have everybody's answer. Just one way or the other. John, did it push you either way? Neither way.
No, it made me more confident there was not an advantage.
Okay, Srini?
Yeah, no, I agree.
Huh. Noel? Meaning it didn't push you one way or the other.
No, it makes me more comfortable with my non-ablation decisions.
Okay, Frank? I may be the only one that disagrees.
I like, I always say that, when I was talking to my wife about intention to treat analysis. Okay, and we were talking about it, and she says, well, it's sort of like this. It's like, well, I don't really care whether you had the intention to do the dishes tonight or put them away, but whether you did them or not. So maybe, is that what you're trying to tell me, that you were just, I was trying to explain that there was a difference if you looked on whether you actually ended up doing it. And she was convinced it only mattered whether I did manage to get the dishes in the dishwasher, not about whether I was intending to do it. So in any case, with that in mind, I think it's important to sort of say, look, the study was designed a specific way. It probably was underpowered. There was untreated analysis that was suggestive. I think there are people that, particularly those with heart failure and LV dysfunction, that will benefit from it. I wouldn't go so far as to tell my patients that they're going to live longer if I do the ablation procedure, but I will tell them that if you're a young person and you have to take anticoagulants for the rest of your life may be a lot more complicated. So, and that's where we are. And whether it helps survival or not, I said there's different ways of looking at this, and it's controversial. We'll see if it can be resolved, but keep that in mind. But I said, more importantly, taking anticoagulation and being with AFib for the rest of your life may add complexity, especially at the times of any surgical procedures, et cetera.
Chris, let me ask you. So you've heard this discussion, and I actually don't know how much you practiced before Cabana came out. It came out relatively recently.
Technically, none at all.
So, and also, as you answer, keep in mind that you still have several more rotations in the EP lab. But very seriously, so when you see all this data and you see the very real issues in terms of Cabana, in terms of the fact that it was underpowered, but to the extent that we have data, the primary endpoint was clearly negative. There are secondary endpoints which are mainly hypothesis generating. I think everyone would agree on that. And you see the other data. How do you look at this?
So I think, and I agree, I actually didn't do any cardiology before Cabana came out, but I think the way to approach it is in a completely asymptomatic patient, there's no change in mortality, or I wouldn't push it for a change in mortality. I think in the symptomatic patient, if I could make them less symptomatic or control it I'd try rhythm control first at least once, and I think after a discussion, if they think that they would like to pursue a catheter or a more interventional approach, I would support them for that. But I don't know. I don't know if I would go for a catheter ablation initially off the bat for the purpose of survival. I think, to talk to other endpoints that, if they have a decreased ejection fraction or if they're symptomatic or they could barely walk to get to the bathroom, I think there's clear improvement in catheter ablation. I would pursue that for more symptomatic approach. But under the answer of pure mortality, or if the question to me is, will I live longer? Personally, I don't think the answer is no. I think the answer is we don't know yet.
Okay.
That's how I would approach it.
So I think
How do you
think
look
that's
at
fair.
this?
What's
How
that?
do you- How do you interpret this? Has it pushed you
Well,
one
so,
way or the other?
yeah, no, I'll tell you, my discussion is very similar to what Frank said in terms of going over, of course, first really trying to rule out whether or not the patient has symptoms or not, cardioversion perhaps, and then if the patient still is asymptomatic, then I have the discussion with them, and I actually talk to them about the data. It's the longest discussion I have when I see an AFib patient, because there's a lot to talk about. And it's very difficult. Now, I'll answer my own other question, which is, which way did it push me? This actually pushed me more. I mean, I actually was very surprised at how positive Cabana was to the extent that it was positive. I didn't expect that, actually. So this actually surprised me in terms of the mortality benefit that was seen in the secondary analysis. Okay, let's move on to heart failure. So there have been a number of studies that have shown that people who have AFib and heart failure, if you get rid of the AFib with ablation, then ejection fraction improves. If you go to the next slide, the camera MRI trial was a little bit interesting. It was interesting because it looked at this a little bit differently. And it said, well, maybe the reason it improves is because you just have better rate control, right? And that may be the problem if there is tachymyopathy. So what if you control the tachymyopathy with the much easier rhythm control? So they randomized patients between ablation and a rate control group, and they actually did achieve good rate control. And what was interesting is, in this situation where both groups have good rate control, there was still an improvement in ejection fraction in the ablation group that far exceeded what was seen in the medical rate control group, which raises this concept of this so-called arrhythmiopathy. And with that, I want to just cut to the clinical trial data and then have everyone discuss. So we know from the most recent ACC and HA and HRS guidelines that in patients who have AFib and reduced ejection fraction, the indication is a class 2B. And this is in the context of knowing the CASTLE-AF data, which all of you know, patients who had AFib and had heart failure, reduced ejection fraction, were randomized to either ablation or control. And there was a statistically significant difference, both in terms of the primary endpoint of mortality and heart failure hospitalization, as well as the individual component of all-cause mortality. And, and with an NNT, interestingly, of only 6. So relatively high event rate in the control group and a substantial effect. This is some more recent, well, on the left is a meta-analysis that looked at, in addition to CASO, camera MRI, ATTACK, and a couple of other trials, again showing improvements in mortality on the meta-analysis, as well as improvements in EF, 6-minute walk, and VO2 max. And more recently, and this hasn't been published yet, but the Cabana investigators presented some of this data where they looked at the 40% of patients who had heart failure in their trial. And what they saw, and this is on the ITT analysis, what they saw was a hazard ratio of 0.59, so a 40% decrease in mortality. Again, this did reach statistical significance. A secondary analysis, but it did include the full cohort of patients. So with that, my question, and then one last important piece of information, because one interesting question is, how do you get a mortality benefit when, the overall success of ablation was reasonable but not great? Here you look in the control group in red and the ablation group in blue, and even the blue group, if you follow these patients out, there are a fair number of them that have recurrence. So the question is, how does that explain the relatively striking mortality benefits? And the investigators, again, they haven't published this, but what they presented is that if you look at this from the perspective of a cutoff of 30%, meaning AF burden decreased, so not whether or not you had no AFib in follow-up, but rather whether you decreased AF burden, that seemed to be very important in predicting both the primary endpoint, the composite, as well as the individual all-cause mortality. So with that introduction, clearly not leading, can I ask, we'll start with Noah. How do you think about this now? When you see a heart failure patient with reduced ejection fraction who also has atrial fibrillation, what's the right thing to do? How do you approach these patients?
The first thing I do when I see any heart failure patient is to try to estimate their stage of disease, because I think that plays a lot into what you all do as far as especially invasive procedures to them. So I think, of course, a stage D patient, I don't think it's something to offer them, but I think we're going to speak more about the stage C patients. Those are symptomatic with structural heart disease, here in this case low EF. And in those cases, really looking at the Castle AF, but also the data before, I really do strongly think nowadays much more, I haven't been practicing for long, but I really do think about ablation in these patients, especially in a center like ours where we could attain success. So it really does come up after optimization of medical therapy, optimization of volume status. That would be, obviously device therapy, like CRT if they need, but that would be on the list of interventions that I would consider for my patients.
Now, I want to go to Sean, but before that, Frank, just your comments on heart failure. You've been in this since the beginning of this whole story. How has your practice changed, if at all, since all these trials have been published relatively recently, actually?
Well, I think it was started when we started doing Afib ablation and recognized that it causes a cardiomyopathy. And just like getting rid of PVCs, the effect was dramatic and consistent. So we knew that in terms of EF improvement, there was unequivocal that you typically in people with importantly, a fast rate, you would get an improvement. Then you had data that would suggest that even without the heart rate being still controlled adequately with drug therapy, that some patients had a decrease in EF. And whether that was because of the chaotic nature of atrial fibrillation and that being a stress that took vulnerable patients and made the EF drop, it was never clear, and it's still not clear to me. But the data, like you see from the MRI trial, really suggests that either it takes longer to recover if you just do rate control and not rhythm control. It's like 2 hits. So the Afib itself doesn't allow for ventricular function to recover, but it would recover ultimately. And maybe it's not 6 months, because that's when the average follow-up was. Maybe it takes a year in that situation. And maybe they would all, over time, they might get to the same endpoint. But clearly, getting dominant in sinus rhythm is the fastest way to get them back to have their function improved. So my threshold for using it in people with depressed function, especially with symptoms of heart failure, I can adjust drug therapy to manage their heart failure, have my colleagues do it, is to get rid of their Afib. And don't hesitate to do it, and with ablative therapy.
No, were you raising your hand? Or you just, okay. No. So Sean, so you have a patient, let's say, who has reduced ejection fraction, and you're seeing them in follow-up, and they just presented in persistent Afib for the first time, okay? You do a cardioversion, let's say, and now they're back in sinus, but then they come back and they start having paroxysmal episodes. How are you approaching this patient, beyond, obviously, optimal heart failure management?
So you'll be probably surprised to hear this, but I favor Afib ablation.
Okay, we can turn off his mic. Let's move on. No, I'm kidding.
Why haven't you seen my patients then for Afib ablation? It's usually the follow-up question. So I would say it's very, very complicated. So I'll say a couple things. So number one, look at the mortality benefits. 40%, 45%, in some cases 50% relative risk reduction with Afib ablation. We don't see any type of mortality benefit in anything that we do in heart failure except for LVAD and transplant. That comes even close to the numbers that are put up here. So I think that while I do believe that heart failure patients, particularly those with reduced ejection fraction, will benefit from Afib ablation, it's very hard for me to have confidence in the data that's presented here. I think there's a grain of truth here. I think it probably misses in terms of magnitude of benefit. If you look at the Castle AF data that you showed before, it was, if you just look at the mortality curves, you can see it goes out to about 3 years before you start to see them split. And when you get to that point, I can't read it from here, but there are probably, 100 patients or fewer than 100 patients in each group at that point. So it's really hard to have confidence even in the Castle AF data to show that there is mortality benefit. The other problem that we have in heart failure is what Dr. Marshalinsky was referring to, and that is that AFib begets heart failure and heart failure begets AFib. So one of the things that Dr. Moss and I do is make sure that whenever we see AFib that develops in our patients is to make sure that their heart failure is maximally treated. And oftentimes once we do that, either with effective diuresis and advancing guideline-directed medical therapy, the AFib tends to abrogate and go away. The last challenge that we have, though, in terms of referring patients for AFib ablation is really in timing. And I think, Noam made a really good point, which is that you got to stage these patients. In stage 4 patients, we're not going to send them for AFib ablation because we're going to be thinking about more advanced therapies. Class 1 asymptomatic patients, those are probably the ones who are going to benefit the most. But when Noah or I sit in front of our patients and we say, well, look, we're going to add another drug and we want to send you for a procedure, the question that always comes next is, do I have to have it? And that's where the data, I think, disappoints us, because you can't really look at the patient and say, well, look, the guidelines say you have to do it, the trial data say you have to do it. We don't have the confidence to say that if you take someone who has heart failure, reduced ejection fraction, who is asymptomatic or minimally symptomatic, that we have the confidence to say that we're going to be actually prolonging your life or reducing your hospitalizations with AFib ablation. And yet, that's my bias. It's just hard to convince patients to do it.
Okay, let's go to something, other potential benefits, if there are, of rhythm control, and let's first talk about stroke prevention, because I have a bunch more things I want to address here. There have been a couple of small multi-center and single-center studies, and these are just two of them. On the left was a multi-center experience in patients who underwent AF ablation. It's notable because it included almost 3,000, actually over 3,000 patients at 5 different high-volume centers, including Frank Center, where the patients, again, this is a non-randomized study, the patients after ablation were either left on or taken off of anticoagulation therapy. And what was interesting is that regardless of the CHAD score, and again, there are relatively few patients in the CHADS, actually here, CHADS greater than 2, but the overall subsequent stroke rate was actually quite low. So that's data point number 1. Notable, again, for the large number of patients. Data point number 2, this is a retrospective study that Jared Bunch published, and there have been several propensity match analyses like these that are even more, that have used multiple more dimensions to match. But this is a study in which you see here, the green line represents the rate of stroke, the blue line, rate of stroke in patients who don't have AFib, the green if you do have AFib, and interestingly, the black line if you had AFib but then underwent catheter ablation. So, and you notice that that line looks very similar to the no AFib, suggesting that ablation would decrease stroke rates. On the other hand, there have been other studies, such as this one. This was published in JAMA Cardiology a couple years ago, the Swedish Health Registry, and there are a couple of interesting points. They looked at about 1,500 or so patients who underwent AF ablation, and what they saw was by 12 months, just over a third of the patients, or close to a third of the patients, stopped their anticoagulation. This is just what they did. And what they saw was in that subset of patients who had a CHADS-VAS greater than or equal to 2, and again, the numbers start becoming smaller, it's about 1,000 patients. What they saw was if they didn't receive warfarin, they did worse in terms of freedom from stroke than if they did receive warfarin. So here's what we have. We have different data going in different directions. None of this is randomized, of course. And I'm wondering, Frank, could you comment on this? What do you do in your own practice, given the fact that on the one hand, you have the data, you know what the guidelines say, which say continue anticoagulation.
I do want to talk about the Swedish study, because this study, the fact is that patients did not have effective ablation.
Yeah.
So ablation does not convey any benefit if you can't get rid of atrial fibrillation. So, I mean, that I guarantee you, and and everybody in the room should agree. The ablation therapy, if it doesn't work, will not help patients have fewer strokes. So, and that's what that study showed. So that's, as far as I'm concerned, it's a fairly poor study because of that. And worthwhile, just to say that there's no magic from having an ablation, but we never thought so. So what do we do? And we want that, it's what also patients want to do. The guidelines now say that you should continue anticoagulants based on the CHA2DS2-VASc score, not based on the outcome of ablation. And there's not a patient that I haven't encountered that said, well, would you anticoagulate me if I'm not having AFib based on my CHA2DS2-VASc score?
Meaning if you never had AFib?
Yes.
Yeah,
If I've never had AFib,
right.
okay, because I am not having atrial fibrillation. So I guarantee it. Check my pulse, I'm happy, I'm not having AFib. Why are you still insisting on anticoagulating? And that's a hard one to come up with an answer. We say, well, the guidelines say so. And that's what we do to talk about. And we say, look, the good news is that we got the guidelines to include a statement to say there are many patients that are reluctant to take anticoagulation and deserve a heartfelt discussion about all the pros and the cons, recognizing that they want to stop the anticoagulation. They're not having AFib. We tell them how important it's going to be to have lifelong monitoring to suspect the possibility of recurrence, to indicate that if their CHA2DS2-VASc is very high, they probably have an independent risk of stroke unrelated to the presence of AFib, and they probably shouldn't stop. We don't stop it if their LA is bigger than 4.8, if they've had spontaneous echo contrast in the lab, if they have a lot of scarring. And I can justify that. I can tell them they shouldn't be on anticoagulation. I mean, they should continue the anticoagulation. Should definitely continue it if they have any of those criteria. However, if they're not having any AFib, and they're willing to assess their pulse twice daily, and or receive a link implant, and either one, because I believe patients need to participate, that's why I like them to be able to assess their pulse twice daily, and take anticoagulants if they either have a call from the link monitor with AFib, or if they develop any significant pulse irregularity, even if they're not sure whether it's AFib or just APDs, that persist for more than 5 minutes, start the anticoagulation. And we allow them to come off the anticoagulants, but they have to be constantly vigilant. Constant vigilance for recurrence. And so far, when we've done that, just with pulse assessment, okay, we had one patient out of now it's to the tune of 300 patient years of follow-up that had a stroke. That patient had significant carotid disease and vascular disease. It was a small lacunar stroke and recovered. It was and was felt to be related to the vascular abnormality. And no one else has had a stroke event. And of course, the only bleeding event has been a minor epistaxis episode in one of the patients that had restarted the anticoagulation. So no major bleeding and no major strokes. But it means the patient has to be vigilant. They have to buy into this. They have to understand that we're deviating from standard guidelines, which is just to ignore what patient's request is and just say you stay on the anticoagulants based on the CHA2DS2-VASc score. And so we compromise, and patients have done well with that compromise. But it's very much important that they participate.
So let me say, John, there are a couple of trials that may shed light on this. Ocean is a large randomized trial, post-ablation patients randomizing to NOAC versus antiplatelet. Option, which is a similar post-ablation trial, randomizing appendage closure versus antiplatelet. Oh, I'm sorry, versus NOAC. My question, and frankly, I'm not convinced that either one of them are going to be definitive, to be frank, because I have a feeling that both of them are going to end up with low event rates in both groups. My question to you is, in this situation, and actually Frank had actually started an earlier trial called OAT, which basically ended up being stopped because we couldn't get patients to actually randomize. It's a very difficult trial to randomize to. So my question to you is, you've been doing anticoagulation, stroke prevention trials for quite some time. And you typically pick populations who are going to have a stroke rate that exceeds the downside, which is, of course, bleeding. What about doing just a very large non-randomized trial in patients who are post-ablation, and you show that their event rate is lower than an X number? If you show that their event rate was less than, let's say, an ischemic stroke rate of 1.2%, I'm just picking a number here, can a NOAC ever beat that? What's wrong with doing this trial like that?
I don't think there is a problem, except that, again, if you don't have events in a trial, it's hard to come up with a definitively positive trial. But it's the way we ran the aspirin low-risk cohort study in SPAF. We picked a
Yeah.
group of people who didn't have risk factors and showed that if you just gave them aspirin, the outer bound of 95% confidence for the event rate would be under 3% per year. And, that's why we don't give anticoagulants to everybody, not because aspirin works, but that they don't need anticoagulation. And you can identify people who are intrinsically low enough risk that you could demonstrate a low event rate on non-anticoagulant treatment. So I think it's doable. It takes a fair number of patients, but it's ultimately arbitrary to set that outer bound of confidence around some number that people would say low enough that it's not worth taking an anticoagulant.
Yeah.
Hopefully-
Can I comment?
yeah.
Because I think that I just like the idea of getting patients to participate in their follow-up and understand there is a risk if they get AFib. It's just, we all know that even if the CHA2DS2-VASc is 0 and if their left atrium's a little dilated, there's probably a risk. And I think it's important in these patients to sort of be able to get them to participate and not just assume that they're low enough risk to say, well, don't worry about it. There is a risk. And I think we should be
That approach that you're taking, I mean, we don't have a great way of assessing the thrombogenicity of an atrium other than its size, and if you've learned something about its fibrotic potential based on what you've learned in the EP lab or some other method, I think those are the ways to make the judgment. I think if you have a thrombogenic atrium, if you're in AFib, the risk is going to be up. And if the AFib is not there, the risk will be lower than it otherwise would be.
So let's just talk for a minute about structural changes that can occur. So I want to go over two pieces of data. This is the ATTEST trial, which hasn't been published yet, but was presented as a late-breaking trial at ESC. And here the investigators looked at the question of whether or not catheter ablation changes the progression of the disease process. So they took patients who had paroxysmal AFib, who failed some antiarrhythmic drugs, and randomized them to either RF ablation or antiarrhythmic drugs. And with the primary endpoint, there was actually progression to persistent AFib at 3 years. Now, they enrolled 255 patients, and the study was actually terminated because of slow enrollment. But interestingly enough, they actually saw highly significant differences in outcomes, both in the ITT population and the per protocol population. What was seen is in the ablation group in red, very few patients actually progressed to persistent AFib versus what was seen in blue, which is the drug therapy patients. And again, both in the ITT and the per protocol analyses with hazard ratios that are, 0.1, so 90% decrease approximately. And interestingly, this happened despite the fact that if you just look at time to first event, and look at that as an endpoint. So the chance of having at least one episode of AFib in follow-up, the ablation group in red, they did do better than the drug group, again, consistent with other trials, but it's not so much better. They did a little bit better in the time to event analysis, again, suggesting that maybe the burden endpoint may actually be the most important endpoint. The other piece of information I want to share with you is this. This is retrospective data and has a lot of potential confounders. But the point is that when you look at patients who underwent AF ablation in 1 or 3 years, so black is 1 year, white is 3 years, the AF ablation patients did better than patients who didn't undergo AF ablation, both in terms of Alzheimer's dementia, vascular dementia, and senile dementia. Again, this is retrospective data. This is not prospective data. So what do you think about these? Anyone? Any comments on this? So when you look at the ATTEST trial, for example, on progression of disease, does that affect how you think about this, Noel?
Yeah, when I talked about the 50-year-old guy.
We can talk about that guy
Not really
again.
about that person, it's really the dementia that worries me. So if we make a branch in the road where I am committing them to persistent AFib, therefore ablation will be harder, et cetera. So the one that goes from paroxysmal to persistent. I put this data, and it's not just data, there's a fair bit of data, and Chris
Yes, there's
alluded
others.
to it.
Yep.
And it just recurrently seems to be true that their mental status is going to take a hit if I leave them in persistent. And that's what makes me worried about not ablating that person,
Yeah.
switching out into a persistent role.
I mean, maybe we'll get something from Cabana. Frank, there are some dementia endpoints in Cabana, right? I don't think any of it, none of that's been presented, certainly.
I haven't seen enough of it so that, to be able to make a statement.
Okay. I think, yeah, the test.
So, I mean, if you're not having a fib after an ablation, why would you progress? I mean,
I'm sorry?
so isn't it, so drugs, ablation is better than drugs for,
In terms of progression, right.
no, just AF recurrence.
Yeah, that's this graph, that's
Yeah,
right.
but that's, this. I mean, that's just saying that you're not having AFib, so you're not progressing.
No, progressing to persistent AFib.
Okay.
No, yeah, I think it was an interesting question.
Is this graph on those patients who had recurrent AF that,
No, the graph you're looking at is just AF recurrence. The previous graph, which is this one, is looking at progression to persistent AFib. What's interesting on this graph is when you look at the previous graph and look at the discordance in terms of progression compared to recurrence. So if you only look at one recurrence, there's going to be a lot of failure. I guess the point I'm trying to get to here is, it's like if you do an angioplasty and then if you did angiograms in every patient for some reason, and you saw that, let's say, the vessel narrowed by 10%. That is progression, right, of this. That's a recurrence of the stenosis. And yet, that has no clinical significance. And the problem we have in the AF field is that we don't have an easy way of measuring burden. And so it's very hard, I think, for us to talk about burden, and hence we use time to first recurrence in all of our trials. But that may not be the best endpoint. Let me go to this. I want to get to risk factor modification, because I find this really interesting. So these are the 2019 ACC/HA HRS guidelines. And if we look, it's a class 1 recommendation for overweight and obese patients with AFib, weight loss combined with risk factor modification, and that includes hypertension management and sleep apnea management, et cetera, is recommended. And this is a class 1 recommendation. The level of evidence is B. And I'm actually surprised they put R because there's actually very little randomized data. But the data that there is, so we have the Legacy trial, which is a very interesting trial that Prash Sanders and his group have published. And they've published several studies in this space. But this is the first of these, actually the second of these, but they looked at 5-year outcomes in patients who fell into 3 groups: those who were able to lose weight, those who lost a little bit of weight, and those who lost no weight. And what they saw, regardless of drug therapy or ablation, was if you lose greater than 10% weight, you have very good outcomes, particularly in comparison to the other groups. And more recently, they published this. This is the reverse trial, which is basically a substudy of Legacy. And what they did, again, if you look at these 3 groups and you look at progression of disease, here's what they saw. Group 1, that is minimal weight loss, saw progression of disease from paroxysmal to persistent, and minimal reversal of disease, versus group 3, which is the greater than 10% weight loss, had minimal progression and significant regression, meaning going from persistent to paroxysmal. So everything looks favorable. It's all good. And in fact, Frank published this manuscript year before last. They put together a nurse-led risk factor modification strategy, including looking at both weight as well as treating sleep apnea. And the first thing they show, in those patients that enrolled in the black line compared to those patients that declined, you see that the enrolled patients actually lost weight. Over the 12 months, they lost about 4% of body weight, which is actually really quite good. If you look at sleep medicine referrals compared to those before they started this program versus those after, at least they seem to be doing a good job of referring the proper patients for this. So this is nice, and they published this in Journal of American Heart Association. However, they published the following year, I guess it just came out, this manuscript. Again, same experience, but now they actually took it one step further and said, okay, now let's look at clinical outcomes. And interestingly, if you look at those patients that enrolled versus declined, there was no significant difference in rhythm control or rhythm freedom. So this is looking at burden, and this is looking at any recurrence. And it's somewhat surprising. So Frank, before you talk, I'm going to go through a couple more pieces of information, let you talk about all of this together. This is also interesting. So in the CPAP world, so looking at patients who have AFib and sleep apnea and saying, let's treat the CPAP. There's a fair amount of preclinical and non-randomized retrospective data that suggests that treating sleep apnea with CPAP decreases AFib burden and other good things. There's no randomized data. This is the only that I could find. Oh, I'm sorry. Oh, this is written wrong up here, but just ignore what I wrote up here. This is a CPAP trial post-DC cardioversion. This was done at Mayo, actually. Looked at patients who had AFib, sleep apnea, undergoing cardioversion, randomized them to additional CPAP or usual care. They screened a lot of patients, 35 patients who underwent sleep apnea testing, 25 had a big enough AHI index, and they randomized them. And again, small numbers of patients, but no real difference in outcomes. And finally, the SMAC-AF. This is a trial that was published a couple years ago looking at blood pressure reduction in patients who are undergoing Afib ablation. So the idea was if you're undergoing Afib ablation, your blood pressure is not normal, you have a history of hypertension, let's either do what we normally do, AF ablation, or do AF ablation and aggressively treat the hypertension, really try to bring it down. And indeed, as shown in blue, they were actually able to decrease both the systolic and the diastolic blood pressure compared to the control group in red. However, there was no significant difference in outcomes. So we have weight reduction, questionable question in terms of whether or not it's effective. Though I won't editorialize yet, but we have blood pressure changes and really didn't make any difference. Treating sleep apnea, again, a very small trial, but the only randomized trial didn't show a difference. What's going on? Frank, do you want to first speak to the weight reduction issue? Because you guys did this.
Yeah, it's not an easy thing to do to get people to convince to lose weight and then to make a substantive change. When you look at the percent change, it tended to be, 5% and wasn't as dramatic as we would have liked. And it took a lot of effort, incredible amounts of effort. So you have to have dedicated people doing it. And the argument was that maybe you need a physician to coax people more firmly, who knows? But it wasn't as dramatic, and it turned out to not be significant. I think it called into question, the amount of benefit that you get, that may be dependent on the degree of weight loss. And
So you're thinking if you got a higher amount of weight loss, perhaps?
Maybe that, again, you start out with pretty incredible obesity, and you're not making a big enough dent in what we did. But it clearly showed that there was not a significant persistent.
So what do you do with your program now? I mean, you guys invested effort.
It's now moved from having a dedicated person that was supported by the hospital. The hospital said, well, we're not going to support it. So, I think they're going to say that anyway, but it's put icing on the cake. And we have now our staff still saying that based on the evidence, that there is important to treat sleep apnea, address your weight loss as much as possible, shoot for a 10% weight loss, because that's probably where it's more convincing. Okay, make sure your blood pressure is under good control, and avoid alcohol. I mean, if you really want to stop AFib, that's what you have to do. And that's what you do.
Avoiding alcohol, I did mention that.
Because patients ask, what can I do? And I say, this is what you can do. And they said, it's not going to be easy, but these are the things that you should try to do and recognize that it may have a role. And it's more to come on this, because it wasn't, it may not be a convincing difference if the weight loss is marginal and you start out incredibly obese.
I mean, and I should point out, there was a randomized trial that some of you may have seen in the New England Journal recently on alcohol avoidance, reduction, whatever, and it had a really important effect in terms of decreasing the amount of AFib, the first randomized trial looking at this. So John, what's going on? Class 1 indication, Class 1, it says here.
Because it says,
What's wrong with your guideline, people?
you know what it is? If you're looking at benefit compared to risk, what's
Yeah.
the risk?
And
Yeah, no,
patients
that's
always
true.
ask, what could we do? What could I do?
That's right.
Yeah.
I say, we're good.
That's the why it's class 1.
So no, absolutely, these are minimal risk interventions. But what do we need in terms of clinical studies? How do we move forward here?
Well, I think the same way it was successful in legacy, you need to look at the people who achieve it successfully and had enough intrinsic risk of whatever the outcome is you're trying to achieve, whether it's AF control or outcome control from clinical events, to demonstrate a difference.
It sounds like a as-treated analysis in Cabana.
It's a big challenge.
Okay. So, Marty, I don't have much more time, right? Okay, so should we ask questions? Why don't we ask the audience if there are any questions?
So similarly, for just going on the obesity, why not look at bariatric surgery? They've already shown cardiovascular benefit with bariatric surgery patients. Why not look at that with AFib as well?
Yeah, so comments? Anyone?
Worth doing, worth looking, good chance it could be a positive study. They'll obviously be selected patients, and they have to be at high enough risk to demonstrate something good's going to happen and low enough risk not to carry additional morbidity from the procedure.
And I don't think our patients are going to quite be ready to volunteer for that de novo. But you never know.
And again, as in most of these interventional trials, it's about equipoise. I mean, I think it's a great study. In fact, Stanford has put that study together. They're planning on conducting it. The problem is, in fact, they asked us if we wanted to be in it, and we actually declined because I don't know how to enroll patients in that trial. You're talking about patients who are coming for AF ablation, who are obese. And I actually, when I see a patient who's very obese with AFib, I try to convince them to go for bariatric surgery, assuming they fit the criteria, of course. But then trying to get them to randomize is a very complicated discussion. So I don't know how to do that. I hope somebody does that trial. It'd be very interesting.
I
Yes?
think beta blockers were mentioned once.
I'm sorry? Oh, beta
Beta
blockers.
were mentioned once. What do they do in paroxysmal atrial fibrillation, and do they have any modification on the rate of conversion to persistent atrial fibrillation? It's a doctor
Anyone?
question.
Frank?
And what's the specific question now? For,
Beta blockers in terms of what's the effect in paroxysmal and does it affect the progression of disease?
well, again, it's a small percentage of patients. What I tell patients, 20 to 25% chance this will decrease the frequency of your episodes substantively and potentially prevent the persistence. I said I don't have the data to be convinced about the persistence, but we can monitor it, and that's the way I leave it. So I say there's some value. I believe in that based on clinical experience, but I don't have the data to support it.
You know, oh, please, go ahead.
With the increased aggression in using the MitraClip for both mitral and tricuspid regurg, and the data recently have shown that you can really get it down to a very small leak, do you think that's going to change the landscape in terms of AFib?
You mean in heart failure patients who have MR? Or do you mean just any valvular regurgitation patients?
I assume that any patient you're going to do an ablation on, you've done an echo. So you know whether they have an underlying regurgitant valve contributing to the problem.
Yeah, I mean, our senses, and again, we may be wrong because it is one of those factors that make things worse. But once you manifest atrial fibrillation, our suspicion is that a lot of patients, the autonomics have changed and the anatomy has changed enough so that even if you eliminate with surgery or MitraClip, et cetera, although small group you eliminate, the experience with surgery has been you don't. So that AFib is still a risk factor, or risk of recurring. So I'm not sure if it'll make a dramatic difference. In some patients it will. There's no doubt that's the stretch that's provoking some of the irritability, and it may be a big difference.
I just want to show a few more.
Okay.
Oh, sorry, go ahead.
Isn't it clear that none of these trials are just long enough? Because, we're talking about looking at the atrium dilate, MR developing. Isn't it certain that that will happen if we let AF continue for 10 years? And then if you're saying that, wouldn't then the recommendation be, I know we need the data, obviously, but then you would be much more proactive in getting rid of it early, or is it not certain that that will happen?
Any comments? No, I agree. I guess, so you're talking specific about atrial stretch and the effects that has?
Yeah, as one of the outcomes that we talked about before, because you did mention that when you see a patient, you look at the atrium, you see if it's dilated over time.
Yeah.
But if you know that's going to happen, anyways, why don't you think about that the first time you see the patient when considering an ablation?
Oh, yes. It's probably not unreasonable. And we do. Do it for prognosis. We do it to determine, whether they're a good candidate. We like it when their atrium's rather.
But it's inevitable that will happen. Is there a data to say that won't happen in some patients, or is it just inevitable that'll happen? We see a lot of.
Oh, no, it's not
Yeah.
inevitable, and that's the magic, right? A couple of things that happen, either both the stretch, the reversal of the stretch, and the size with effective ablation.
Right.
A lot of variability, and some things are predictable, that is more scarring, et cetera, but most of it is uncertain. But overall, the left atrium does shrink with restoration of sinus rhythm.
Right, and if you don't do that, it will inevitably dilate, and you'll develop MR and TR. 'Cause, we're seeing a lot. We're seeing a lot of patients now for evaluation of percutaneous interventions on their tricuspid or mitral valves when they're 80 and 85, and it's a lot of them have chronic AF, and their atrium are huge, and that seems to be the mechanism of a lot of their valve disease in the 70s and 80s, I think. And you always wonder, what if we would have intervened on that AFib earlier on?
I think it's really important. That's why I said that one thing I do look for the asymptomatic patient. If they have MR that's gone from mild to moderate, I try to fix their AFib.
It's one piece of information that you might find interesting. There was a mechanistic study conducted a couple years ago where the investigators wanted to ask the question, what is the effect of atrial stretch on atrial electrophysiology? So they looked at patients who are undergoing mitral stenosis relief, so balloon valvuloplasty, okay? Now, obviously, it's rheumatic disease, a little bit different physiology, but whatever. What was interesting is they mapped the patients just before, like literally in the same procedure, just before relieving the mitral stenosis and immediately after. And you see tremendous differences, literally within minutes of relieving the pressure. So atrial stretch has a really incredible effect, and relieving it has a relatively quick benefit. Now, is that enough benefit and whatever, that's a different question, but I just thought that was interesting. Just two other pieces of information. Autonomics may end up playing a bigger role. This is the Eradicate AF trial, which was recently just published. It was an interesting trial. Patients were randomized to either AF ablation or AF ablation plus renal denervation. So these are patients who had some degree of hypertension and planned for AF ablation. And what they saw was in those patients that had additional adjunctive renal denervation, there was almost a 50% decrease in AF recurrence, or 40% decrease in AF recurrence. That's an invasive procedure. Here's another one, very interesting. This hasn't been published yet. This is tragus nerve stimulation. So Sonny Poe and his colleagues have been working on this. There's a lot of preclinical data that supports this, so this is not as crazy as it may initially seem. But basically, patients were randomized to electrical stimulation of either this thing, the tragus, which is where the tragus nerve is, or the earlobe, which there's nothing here. So this is the intervention group, this is the sham group. And they underwent, basically, they had this external stimulator, you wear this clip on your earlobe or your tragus for an hour a day, and then they looked at what happens in terms of ambient atrial arrhythmias in a group of patients who had paroxysmal AFib. And what they saw, compared to the sham group, there was an increase in AF burden over time. In the active group, the stimulation group, there was actually a decrease, and this was statistically significant. So, and they showed there was decreased TNF-alpha, the marker of inflammation. So this idea of nerve autonomic modulation, whether it's invasive renal denervation or peripheral nerve stimulation, does seem to be interesting. Obviously, this is not something you can do every day. In fact, if you want to buy this nerve stimulator, you got to buy it from the UK, and it costs about $700, just in case you were curious. What do you think about this, autonomic modulation? Srini, what are your thoughts on this? Not necessarily this, though, this also.
Yeah, look, we need to see more data, I think. So I said we need to see more data, randomized controlled studies about the autonomic modulation, all the various forms in terms of AFib. I think there is a potential benefit, but we have to wait and see.
I should note, this is a 392 patient study. 300 randomized patients. So it's not a small study. Having said that, there are no catheters approved for renal denervation, so this would be certainly off-label use. And this was actually conducted outside the United States. Any other questions or comments? No? Okay, thank you very much.